Okay, good morning. Beneath the surface, OCT insight and choroid pathologies. Here I will be discussing the common diseases like dry and wet AMD, PCV and CSCR, the OCT features. As we know, OCT plays an important role in identifying pathophysiology of common chorioretinal conditions and provides high resolution cross-sectional image of the choroid. And advanced techniques like EDI OCT, SSOCT has helped in better visualization of choroidal vasculatures, sclerochoroidal junction and better idea into the disease pathologies. So coming to dry ARMD. Dry ARMD is characterized by presence of drusen which are focal white yellow excrescence, and usually these are large drusen more than 125 microns, and in OCT we will get discrete elevation of the RPE, and here in second image we can see the bumpy RPE which is caused due to the drusen, and these are hyperreflective. And another entity is pseudodrusen or reticular drusen, which is highly correlated with development of end-stage subtypes of dry AMD, and usually these are seen in the sub-RPE space, that is above subretinal space above the RPE. So drusen we will get in sub-RPE and reticular drusen will be seen in the subretinal space. Next is coalescence of this drusen can result in drusenoid PED, which is the elevation of RPE with a dome-shaped configuration, and usually this will be more than 350 micron in size. Here we can see the acute elevation of RPE with hyperreflectivity beneath, and this is drusenoid PED. And coming to the advanced stages of dry AMD, we have IRORA, that is incomplete retinal pigment epithelium and outer retinal atrophy. It is characterized by subsidence of inner nuclear and outer plexiform layer, that is the arrows, and signal hypertransmission into the choroid due to the loss of RPE and the layers. And if the area of this disruption is more than 250 micron, it is called CRORA or complete retinal pigment epithelium and outer retinal atrophy. And finally, we have geographic atrophy, which is the late manifestation of dry AMD, in which we can see localized sharply demarcated atrophy of outer retinal tissue and choriocapillaries, and in OCT we can see absence of the outer retinal layers between the yellow arrows and absence of RPE, and due to the absence of RPE and thin choroid, hypertransmission can be seen just beneath this layer. Next is neovascular AMD. Neovascular AMD, the growth of abnormal vessels in the macular region and leads to structural changes in retina, and new vessels arise from the choroid and penetrate the Bruch's membrane, can result in fibrovascular tissue beneath or above the RPE, and this new vessel can also arise from retinal circulation. And this CNVM can be seen as hyperreflectivity, and if it is beneath the RPE, that is below the RPE, it is called type 1 CNVM, and if it is above the RPE, as in second image, it is called type 2 CNVM. In here hyperreflectivity is seen in the neurosensory retina, and sometimes we can get a mixed type in which both type 1, that is above and below RPE, can be seen, and there is a type 3 neovascularization in which the neovascularization arises from the retinal capillaries and goes into the choroid, and it is characterized by presence of serous PED with cystoid edema overlying the PED and intraretinal hyperreflectivity complex and subretinal fluid. Next is another sign of activity in CNVM, that is intraretinal and subretinal fluid. Intraretinal fluid can range from mild retinal thickening to cystoid spaces, large cystoid spaces, and subretinal fluid we can see as optically clear area between the RPE and neurosensory retina. On the both sides of this PED we can see subretinal fluid, those arrows, white arrows. Then pigment epithelial detachment, that is the separation of RPE from Bruch's membrane due to presence of fluid, blood or fibrovascular tissue. If the separation is due to fluid, serous fluid, it is called serous PED and is characterized by sharply demarcated dome-shaped elevation of RPE, and beneath it there will be homogeneous hyperreflective space and Bruch's membrane, underlying Bruch's membrane can be made out. Then we have fibrovascular PED, which is characterized by irregular elevation of the RPE. Here the RPE is elevated irregularly and there will be heterogeneous content, that is both hypo and hyperreflective contents are seen. in fibrovascular PED. And third type of PED is hemorrhagic PED, in which CNVM membrane bleeds into sub-RPE space or due to RPE tear. And this is also acute elevation of the RPE. There is a dome-shaped elevation of RPE with hyper-reflective material can be seen beneath the RPE layer, and due to the backshadowing, underlying Brooks membrane cannot be visualized. Next is the end stage, that is deciform scar, in which the retinal tissue is replaced by scar tissue. We can see hyper-reflective material there, and there is marked disruption of the retinal architecture. And another thing is outer retinal tubulation. These are seen in the circle, that is hyper-reflective structure surrounded by hyper-reflective band, and this has to be distinguished from the cystoid space, which is cystoid space is a sign of activity, and this is a sign of chronicity and no need for treatment. Then another entity is central posterior vitreous fibrosis, which we can see in late stages, where there is an unusually adherent posterior hyaloid which thickens at the fovea, resulting in the filling in of foveolar depression. Next is PCV. It is considered to be a variant of type 1 CNVM and is a part of pachychoroid spectrum of disease, characterized by presence of serous polyps, presence of dilated polyps, severe exudation, serosanguinous maculopathy, and hemorrhagic PEDs. And there are some OCT features which are distinctive for PCV, and it include large PEDs, thumb-shaped PEDs. Then we have sharp peak PEDs and notch PEDs, and here in the notch, near the notch, we can see a hyporeflective lumen, that is in the red arrow, which is surrounded by a hyperreflective ring, which usually correspond to polyps. Then other signs of activity like hyperreflective material, intraretinal fluid, subretinal fluid can be seen. And we have double layer sign, in which there is shallow detachment of RPE distinct from Brooks membrane, and there is hyperreflectivity in between the layers. It represents the presence of abnormal vascular network. Next we have CSCR, which is the serous detachment of neurosensory retina, and is characterized by presence of optically clear fluid-filled cavity, and it is considered to be a part of pachychoroid spectrum, in which the choroid vessels are dilated in both affected and fellow eye, and this enlarged vessels can compress the choriocapillaries, and ischemia of outer retinal layers occurs, and resulting in diffuse pigment epitheliopathy, which can later lead to CSCR. And it is also in CSCR we can see serous PEDs in almost all eyes, and size of the PEDs can be larger, and in late cases we can see flat irregular PEDs which are shallow, hyperreflective, broad elevation of RPE. Then we can see focal RPE rip, which corresponds to area of leak in FFA, and double layer sign just like PCV can be seen, but here we can get uniform hyperreflectivity. And coming to the signs of chronic disease, we have hyperreflective dots. In the first image we can see hyperreflective dots overhang the roof of SMD, and this represent the photoreceptor outer segment. Then cystoid changes, fibrinous materials, and flat irregular PED, which corresponds to double layer sign, which is a indicator for risk of neovascularization, can also be seen. Thank you.
Thank you, Parvathy, for this insight.